Now, before we get started, I'll introduce our speaker. Dr. Margaret Bauman is a pioneer in the study and treatment of autism and is highly respected by her fellow clinicians and patients for the level of clinical care she provides and the advances that she has contributed to in the field. Dr. Bauman is a neurologist and specializes in the diagnosis and treatment of autism and various neurological disorders in children, adolescents, and adults, to include learning and developmental disabilities, seizures, cerebral palsy, and neurogenetic disorders. Dr. Bauman is the founding director of the LURIE Center, formerly called Ladders. She also established the Autism Research Foundation, the Autism Research Consortium, and the Autism Treatment Network. She has also made significant laboratory research contributions in the neuroanatomical understanding of autism.
So we're delighted to have you with us and hope some good questions come out of this today. So just beginning where we started, as most of you know, there was the original diagnostic in 1994 in its 4th edition at that time. And these were the nomenclatures, the labels that many of us used for many, many years. In 2013, however, a committee came together and changed many of the nomenclatures to the extent that Asperger's syndrome was removed, as many of you know. The core features of autism have remained stable, so that people are still talking about social interaction, delayed and disordered language, and isolated areas of interest, and all of you are aware of that. Inconsistent features, and this is a very variable disorder, as everyone I'm sure on this call are aware. But some of the kids have this what's funny, I talk about atypical intonation in their voices. They have trouble sometimes understanding the intonation in the voices of other people. Sometimes it's echolalia, it's a lot of scripting, sometimes pronoun reversals, repetitive and stereotypic behaviors. Some of them have it, some of them don't. A lot of the kids like to have routine. They have difficulty with novelty. Some of that can be anxiety provoking for them. They have low muscle tone. Many have poor motor coordination. There seems to be an atypical information processing component and also a good deal of sensory dysfunction in a variety of ways. Some of them are sensory seekers, and some of them seem to be overly sensitive, and some of them have both. In terms of the baby studies that have been done and reported for many years, we came up with some of our own categories. One of them was what we called the socially serious baby. That is, if you try to get this baby who is 3, 4, or 5 months old to smile, some of these little babies just don't seem to respond. There's a lack of social reciprocity, so checking back and forth. Usually, most babies have developed pretty good head control by the age of 4 months. And what we found in our infants, particularly in a baby SIBS project, where we were looking at younger siblings of children on the autism spectrum, that many of these babies still had head lag at the age of 6 months. And we felt that that was a marker for potential risk factors for autism down the line. And that did seem to be the case, and this was ultimately published by one of our fellow occupational therapists. That's not to say that every baby who exhibits head lag at 6 months is going to be on the autism spectrum, but if this is a high-risk baby, what it does say is that these are the kinds of children that really need to be monitored very carefully. Other components that came out of the baby SIBS observation with atypical motor patterns, difficulty crawling, sometimes it was delay in walking, sometimes it was awkward in walking, poor balance, and so forth. There was also this, what we call the maternal still face. So the mother would stand in front of the baby, try to engage this baby, smile, make noises, and so forth. Then all of a sudden, we've asked her to just stand in front of the baby with no facial expression at all. Most typically developing babies will look at this mother and be very worried, and why aren't you responding to me? And they will start making noises and moving around and trying to attract the mother's attention. The kids who really look like they could care less. They looked around, they did something else. It simply didn't bother them that this mother was not engaging with them. And so then this was part of trying to look at early markers of what we could do in terms of making earlier diagnoses. So this was something that we thought was reasonably consistent, but again, not a one-size-fits-all. Early diagnosis, I think that many of us feel can be made as early possible currently as 12 to 14 months. And I don't know, so far everybody's been looking for a biomarker so we can try to pick this up earlier. To my knowledge, we don't have it, but that doesn't mean we aren't looking, and we certainly are looking. Diagnostic disability out of most of the research is probably confirmed at around just short of the 3rd birthday. What they mean by that is that there's so much variability in terms of developmental trajectories that we can see some variability just in typically developing children. So in order to be absolutely certain that the child is on the spectrum, most people are saying you really have to wait until they're about 36 months old. I think most of us don't believe that we're going to sit around and wait till the age of 3 before making this diagnosis. And I think that everybody who has been involved in this field and has a lot of experience, I think most of us feel reasonably pretty comfortable, even in 18-month-olds, of picking up something that we feel like is worthy of intervention and therapy. So I suppose we could still say we have to be absolutely certain beyond a reasonable doubt that maybe by 3 years, but certainly I would not delay in any way making a diagnosis before that if you felt it was definitely there. All etiologies, there are a myriad of suggested etiologies, but I think the most common and uniformly accepted is genetics and epigenetics, and perhaps genetics plus environmental factors are sort of the going idea. I think that the issue is that not all of these children have not identifiable genetic markers. Children who are referred because someone is concerned about a possible diagnosis of the spectrum are frequently seen by a developmental pediatrician or a child neurologist or possibly a psychiatrist. And a past history is obtained, a developmental history and so forth. Oftentimes people will go ahead and do chromosomal analysis. Sometimes some of them will do a routine EEG or a routine MRI or metabolic studies right from the get-go. I personally do not do all of that, mostly because I think EEG has got its own variabilities. I'm not sure imaging studies really tell us very much right now unless your baby or your subject is part of a research study. Yes, chromosomal analysis that we do, although maybe not right out of the box. And metabolic studies we'll talk about a little bit later, but what initially happens in that first visit I think is really quite variable. Anyway, we do our usual examination, try to find out what's going on. Is this a child who's had some of the symptoms we've already discussed and so forth, but many of them will present with some kind of behavioral concerns. And even kids that we've been following for a while may have some behavioral concerns that go far beyond what would typically seen in an ordinary child, a typically developing child. And oftentimes these are just attributed to the child's being on the autism spectrum. And I think that this has been a big mistake, and I suspect some of you have heard me say this before, and that a lot of these disruptive behaviors can have other causes. And I don't think that they're necessarily simply part of the child being on the autism spectrum. So what's the definition of behavioral? Why might they have some behavioral difficulties? Well, it's how an organism, in this case a human, responds to social stimuli or any kind of stimuli in the environment. Research has now said that many children, even typically developing children, will develop odd behaviors or atypical behaviors or being irritable behaviors just because they don't feel well. And physical illness can certainly be very common in children with developmental disabilities, including those on the spectrum. There's some data to suggest that those with developmental disabilities seem to have a higher rate of chronic medical conditions, but I think that's maybe because they aren't always getting the medical care they need in the first place. I'm not sure that they're always more prone to that necessarily, but we do see it fairly frequently. Problem behaviors have been linked to comorbidities, medical conditions that are ordinary in ordinary people, like constipation and allergies and so forth, ear infections. And the reasonable thought is that these kids will have some odd behaviors or irritable behaviors because they're uncomfortable, they're in pain. And as many of you know, many of them are nonverbal, And even those kids who are verbal have difficulty identifying their pain and discomfort, or relating it to other people, or identifying where it is or what it is. So their one way of expressing this is through behavioral disruptions of one type or another. So what kind of healthcare conditions are fairly common among the autism population? This is a brief list, and I'd like to go down some of these items first, and then we'll talk about other items more broadly. It's well known that approximately 1/3 individuals on the autism spectrum develop seizures at some time during their life. Some of them can be very minor seizures and be very easily controlled. Others can be very complicated and be a lifetime disorder. Oftentimes, though, sometimes they can be difficult to diagnose because the way that they present. It could be simply staring, it could be some kind of odd movement that who knows what that odd movement might show, and so forth. So getting an EEG certainly can be very helpful. My personal preference is to do a 24 or 48-hour EEG if we can get the children to keep the electrodes on their head for that length of time, because they don't like things on their head. But if we can possibly get something that long, that really is much more helpful than a routine EEG, which is maybe 20 or 30 minutes maximum, and would be very easy to miss any kind of abnormality that might be there. One of my favorite things to do, quite honestly, if somebody is presenting with some kind of behavior that's being suspected of being a seizure, is to ask parents or teachers or therapists, whoever is working the child and reporting it, to try to record the event of some similar event on their cell phone, and then show me what it is that you're describing here. And this came up several years ago when I was seeing a child on the West Coast who had been treated for seizure disorders for 1.5 years, and I was seeing him because I was then the 3rd neurologist, and the issue was that he was having these seizures, and he was being treated, and they were still going on, and nobody seemed to know what to do. And I was getting the history, and being a neurologist, of course, you think about seizures the way you think about seizures, because that's what you're trained to think about. Anyway, about 2/3 through the visit, the mother said, "Oh, by the way, I have a video of one of these episodes on my cell phone." So she turned on the cell phone, and what I ended up seeing was not seizures at all, but it looked like a child who was in pain from gastrointestinal dysfunction, and he was curled up on the floor and having these behaviors and such. Long story short, he got sent to the gastroenterologist, had an endoscopy done, turned out to have esophagitis and gastroesophageal reflux disease. This was treated, and the behaviors went away. So I think I find it personally very helpful if I can see what it is that the family's describing, because sometimes I'll get a picture in my head of what I think they're describing, but then when I see the actual picture, I realize that I didn't understand what they were really saying at all. So I think if in fact someone could grab a video of any of these events, sometimes, particularly if they're subtle, that's often extremely very helpful. Sleep disorders are fairly common. And if this child's not sleeping, then nobody else is sleeping. It can be problems getting to sleep or staying asleep. They can be sort of an abnormal sleep cycle. So sometimes the children have sort of turned night into day and day into night. One has to think about the possibility of a gastroesophageal reflux disease. We have seen this frequently in this population, particularly with difficulties getting to sleep. And we'll talk about that a little bit more in a minute. Sometimes allergies, or your nose gets stuffed up. It could be that you've got big tonsils and adenoids, so you're really not breathing very well. So that could be an issue. It could be sensory processing disorders. There's a number of these children really like deep pressure. So last holiday, last Christmas, there was a big push just on the general market of selling weighted blankets, which I was sort of amused about, quite honestly, because clearly other people are concerned about sensory processing and getting some good night's sleep if you have some kind of deep pressure that you're sleeping with. So sometimes things like that can be very helpful, particularly in the autism group. Gastrointestinal issues seem to be growing in terms of their interest. Many of these children have very limited diets. They tend to be high carb eaters. It's sort of a funny joke that people say, well, the diet of the autistic child is pizza, French fries, and chicken McNuggets, and probably that's about it. Constipation and diarrhea can occur, abdominal pain, cyclic vomiting, and there are some kids who have a tight rectal sphincter so that they have difficulty producing a stool. In any case, oftentimes any of these things can cause pain and discomfort. And I'm now at the stage as a clinician that when someone comes in with unusual behaviors that are particularly those of recent onset, the first, almost next referral is to a gastroenterologist. I feel that they're that common that we need to rule out some kind of GI tract disorder. Now, what kinds of symptoms would be typical? Gulping and facial grimacing can often be very common in these kids, particularly those with the reflux. Tapping on the chest or stomach, putting pressure on the abdomen. I remember seeing a child come in. I was working with an occupational therapist. This actually was an adult. Came in and headed right for the sink and leaned over the sink and put pressure on his stomach. And remember, the therapist said to me, I think this man has GI tract problems, which indeed he did have. It was sort of interesting. Constant chewing on non-edible items such as shirt sleeves and the neck of shirts and so forth. And we've probably seen lots of kids that are like that. The theory is that if in fact you've got irritability or discomfort in the esophagus, that what you're doing is you're creating saliva by chewing on a non-edible. It could be a chewy, it could be a toy, it could be whatever's in the environment, but they're creating saliva, and saliva is feeding to the esophagus. So the theory is that anybody who's looking at this, we really do need to think about looking at some kind of irritability in the esophagus. Frequent eating and drinking, same story. If you're constantly nibbling and something that's going down that esophagus that hopefully is helping you, and that's why a lot of these kids may be doing this. At least once someone needs to think about it and at least consider that potential cause. But as I said earlier, any negative behavior that's shown up that looks unusual really deserves a GI consult. And I will tell one other anecdote. I had a young lady, age 21, who showed up in my office, hitting her head, and her one phrase was, head hurts, head hurts. And I remember saying to the parents, I know you're going to think I'm a crazy lady, but I really think your daughter needs to see a gastroenterologist. She goes to see the gastroenterologist. Yeah, she was diagnosed with reflux and esophagitis, got treated, and there's no more head hurts. So I don't think it meant that she was having a headache. I just think this was one way she was expressing that she was uncomfortable. So again, thinking a little bit out of the box and across our respective disciplines, I think is sort of the message here for a lot of these children. They don't present with the symptoms that most people would recognize in typically developing kids. Urology, how often do we send these kids to a urologist? Perhaps not very often, but they do happen. And yes, they can have urinary tract infections just like anybody else. But there are a group of kids who, just before adolescence, seemingly, at least in our small sample, seem to become suddenly incontinent for no particular reason. And people start thinking about some behavioral issue, is he anxious, and so forth and so on. Have been sending some of these children to a urologist, and a diagnosis of what's called spastic bladder has been made. I don't know why they developed a spastic bladder at that point, but there seems to be a subset that do. And it is a treatable disorder. Ditropan is one of the methods, but there are others. So it is important, to look beyond the obvious and say, is there something that we're missing here that's a treatable disorder that we need to look at? What?
Apparently you're cutting out again.
Oh,
Your thing.
okay.
So,
Just hang on a minute.
well, she's typing to me.
So you can switch to the phone handset?
Yeah, she's working on it.
Perfect.
So,
Margaret, hey, while we're doing this, could I ask you a quick question?
Sure.
Could you repeat the part about chewing and saliva? So you were talking a little bit about that connection, and it just cut out a little bit. This wasn't anything like earlier, so it was just a brief little cutout. Could you talk a bit about that a little bit more about chewing and sleeves?
Okay. The theory between why some kids seem to chew on non-edibles. The theory in the gastrointestinal world is that many of these children can have irritations in their esophagus, and by chewing on non-edibles or drinking or snacking is creating saliva, which then soothes the esophagus. I don't think that they're consciously doing that. I think they've just done it. They've discovered that by doing these various methods that they feel better, so they keep doing it. So, you know, just because it could be a sensory issue for other reasons, like the occupational therapists will frequently talk about, but in large part, if I see a child who's doing that, I really would want them to see a gastroenterologist to rule out reflux. So what do I need to do?
Figuring it out. And figuring it out.
Okay, we're still working on it. Can I still go on?
Yes, keep going, Margaret.
Okay, all right. So metabolic workups. One of the things, there's a growing body of literature right now that's looking particularly at associated mitochondrial disorders. Mitochondria are the inner engines of every cell in your body. And there initially was some idea that this could be related to autism, but there now is a growing literature that suggests that at least in a subset of kids, that there could be an associated mitochondrial problem. Our clinical red flags for that is that what would make me want to work up a child for this potential disorder? And one of them would be poor physical endurance. So the child who goes to the mall or someplace with a walk with his parent and wants to be picked up after 2 or 3 steps or riding in the baby carriage or whatever. Most of these kids are the Energizer bunny. They have tons of energy and their physical endurance is phenomenal. So to find a child whose physical endurance is low and who fatigues very easily is unusual. Kids who are late walkers, most of these children, although they may have motor problems and low muscle tone, tend to walk on time. If you've got a child who's a late walker, then this is something that at least should be considered. Kids who have repeated regressions. Now we're used to hearing about some children who seem to lose their skills at around 18 to 20 months of age. That's not, I wouldn't say it's a common problem, but it's often enough that people get concerned about it. But after the age of 2.5 years or thereabouts, if you see this 2 or 3 times a year, this is unusual and really would merit further investigation and possibly looking for a mitochondrial disorder. I think dysmorphic features, not necessarily related to mitochondrial disorders, but certainly a suggestive factor. Making poor progress despite excellent services. These kids who are getting 40 hours a week of everything, lots of OT, lots of speech and so forth, and are just creeping along. You have to say to yourself, what is holding this back? He or she should really be making much more progress than they are. There's something that's standing in their way. And this has also been something we've looked at. Kids who are what I call qualitatively different. You look at this particular child in front of you and you say, yeah, he meets criteria for autism, but there's something a little bit off about this kid. I can't put it into words. It's hard for me to describe, but I just feel like there's something else going on here. And that's another child that I would look at. And then lastly, kids who have multiple organ systems involved. So if you've got a child who's got allergies, who's got GI tract issues, who's got sleep problems. So we've got multiple things going on here. Should we be looking for something that's going to affect multiple systems, such as mitochondrial disorders? We did publish, what? Do you want me to go on? Hello?
Hey, Margaret.
Am I still okay?
You're good.
Okay. Okay. In 2008, we published a paper. I'm getting feedback, but okay, we published a paper which included 25 patients, and I won't get into the details here, but anyway, it's in the literature. The first author is Weissman, and it really describes 25 patients who presented with some of the symptoms I've just described. And excuse me, I have to get a drink here. Sorry about that. Sorry. Who we found who then eventually had muscle biopsies and were finally determined to have either complex 1 or complex 2 mitochondrial disorder. But we wrote this up, and I would urge people to take a look at the literature to see what it is. The reason for going through all of this is that we often will treat some of these children with what now is called a mitochondrial cocktail, which involves a number of substances that mitochondria rely on for their energy. And many of them have improved. And that's not to say that's the end all, the be all. And there are certainly some kids who have not responded. But we have another project in the works where we're about to report some of the successes that we've had using this method of intervention. It's not curing anybody, but if we can give these children a leg up, all to the good. So psychopharmacology is something that we also want to talk about. One of my concerns is that sometimes children who present with behavioral problems get sent to the psychopharmacologist or the psychiatrist and are automatically put on some kind of medication like Risperdal or Abilify or some other medication. And my guess warning would be that I think they need to have their medical conditions looked at first. I don't think that medication should be the first line of defense. I think we need to rule out any of these other medical disorders, because if we've got a child who's got GI tract issues and that's why he's got behavior problems, no amount of Risperdal or anything else is going to make much of a difference. We need to treat what the underlying cause is if we can identify it. So we have to consider the symptoms that are being exhibited, particularly things like depression or anxiety, OCD behaviors, impulsivity, ADHD, and so forth. And any or all of these can appear in this population. When choosing a medication, I think we have to choose one that the risks and the benefits. And my experience is that many of these children do not respond to medication quite the same way as typically developing kids do. So I often will work with a psychiatrist who's knowledgeable in working with individuals, children, adolescents, and adults on the spectrum, and who can work with me or by themselves for that matter, picking the right kind of medication for the right person. I think when the family is seeking a psychopharmacologist or a psychiatrist, they need to find somebody that they're comfortable with. They need to have somebody who is going to listen to them, who's going to answer their questions as clearly as possible, and who won't think that what they're talking about is, pardon the expression, stupid. The choice of medications that are used is frequently influenced by the training of the provider. So you train at one institution, you might prefer X drug, and if you train someplace else, you might prefer Y drug. But I think most of them are pretty well trained to do what's correct. Healthcare insurance may influence the choice of a medication. If you have a healthcare insurance that only pays for certain amounts of medication or certain brands of medication, that can be a challenge. Medical risks to the patient, the cost of the patient, potential invasive procedures. So am I going to have to draw bloods? Am I going to have to do an EKG frequently? Am I going to have to check blood pressure? All needs to be considered. The tolerance of the effect and any potential drug interactions all need to be considered. And then certainly methods of administration. Some of the children won't take pills. Some of them won't take liquid. Sometimes you have to use a patch. So there are complications here. Would that it would be simple, but of course it's not. So other medical conditions besides the ones that we just talked about, we've got a lot of kids who gain weight. Sometimes it's medication related. Sometimes it's because they're not very energetic or athletic. Sometimes because they're eating high carb meals or they're constantly eating. There could be a whole host of reasons, but it seems to be fairly common in this population. Osteoporosis, that's come to light, and there's a growing body of literature about that. Largely, I think the theory is because there are families that are putting their children on dairy-free diets or gluten and casein-free diets, and I'm not saying that those diets are wrong. It's just that we have to be sure that the kids are getting adequate calcium intake, and that may not always be the case. Otitis media certainly can occur in these kids just as much as anybody else. And oftentimes it's very difficult to tell. Again, they cannot point to their ear. They can't tell you that they've got an earache. And it's just going to have to be, I've got to check out this child to see if there's anything here I can identify. Same thing for dental issues. Suppose we have problems with the wisdom teeth, or we have cavities or something of that sort. We need to be able to look, just go down the line. What or systems do I need to look at? PANDAS has gotten a lot of interest. This is a response to, believed to be a response to strep infections, and can lead to OCD behaviors and perseverative behaviors, irritable behaviors of all kinds. This is a treatable disorder for most part, but needs to be identified.
Okay, so the LADDERS team. Why do we need the LADDERS team? Well, I think that the LADDERS stands for Learning and Developmental Disabilities Evaluation and Rehabilitation Services. And so that's a big long label, and so we ended up simply calling it LADDERS. And this was a concept that came from the fact that there's a growing appreciation of the fact that we've got children, adolescents, and adults who have a variety of conditions, and that this is much more complex than I think people have appreciated from the beginning, and that we were going to need multiple disciplines and points of view in order to diagnose and treat these individuals effectively. So yes, this is a very complex disorder, and it's in most cases goes well beyond just the brain. Further, as everyone knows, we said early in the beginning that these individuals are heterogeneous. They aren't identical anything. So what works for child one or person one doesn't work for another, and we have to each one of them has to be seen as an individual. We need to try to find the right individual intervention for each client. So we need multiple perspectives here to determine and guide these services for each patient. The LADDERS team is, I think, fairly broad. We've led it, because I'm a neurologist, neurology is the top of the list, but it doesn't need to be. But the team, as we put it together, included neurology, developmental pediatrics, child psychiatry, also adult psychiatry, adult medicine, because we were seeing children, adolescents, and adults, gastroenterology for obvious reasons, neuropsychology, because we need to be able to do evaluations on these individuals to find out what their strengths and weaknesses are, what kind of services do they need, educational programming. We needed an education specialist to do some of the testing for the educational kids, but also, frankly, to help families navigate the school districts. So by having an education specialist, this would allow this person with credentials and credibility to go in, for example, and to make a classroom observation. Yes, this child has an educational plan, but is this educational plan effective? Is he or she able to take advantages of the services that are provided? Do we need to change something? And then to help the family by attending the school meeting and advocating for any changes that might be needed in the school program. So that person played a very prominent role as part of the team. Social worker was definitely involved in helping families seek resources, as was what we call the family resource coordinator. The LADDERS program saw children not only locally, but many of them were referred from out of state or certainly out of the local community. And if that was the case, we needed somebody to help families locate resources in their community, and they needed to be knowledgeable services. It just couldn't be, you need to go find a speech pathologist recommendation. It needed to be somebody who really knew what was going on, what kind of things that would benefit the child, the adolescent, or the adult in question. So that was the responsibility of both of these individuals. We then also had occupational therapy, physical therapy, and speech therapy. And frankly, as a neurologist, I personally learned a great deal from each one of these. As a physician, most of us have very little exposure as part of our training to any of these disciplines. And I think that by working with other specialists, I learned a great deal about how to see different presentations from a different point of view than I had been trained to know about. So each one of these really has contributed tremendously, and all, by the way, are needed in this field in one way or another. Audiology, yes, particularly because we have a subset of children, adolescents, and adults who have difficulty with what's called central auditory processing. Yes, some of them do have hearing issues, that's true, but I'm also interested in how do they handle language as it increases in length and complexity? And can that be misinterpreted as an attention deficit disorder? And if it is, then we're going to get children who are going to get treated with medications that maybe they don't truly need. Maybe they need a different kind of approach. We used a clinical manager, and we, of course, also had a nurse on board. Now, not all of the services that these kids need, or children, I don't say kids, but, you know, children, adolescents, and adults, because you know that I'm using the whole lifespan here, cannot all be encompassed in a single entity. So we had to develop a sort of a network of people in the community with whom we could collaborate and who also could help us provide services that we felt were going to be quality services and with whom we could work ongoing. So we had dentists, behavioral psychologists, orthopedists, because we certainly got a lot of kids who have orthopedic concerns, endocrinology, medical genetics, ear, nose, and throat, developmental optometry and ophthalmology. Do we have kids who have difficulty with visual tracking or depth perception, for example? Sleep disorders, I mean, like sleep specialists, dietary issues. So, you know, we talked about the limited diet that these kids have. Urology and nephrology, we talked about that. Assistive technology is huge, particularly for those children who are nonverbal or have very limited verbal capacity. But really, many of them are fairly smart and get frustrated by their failure to be able to communicate. Legal assistance, yes, so many of these families do need help. They need help getting insurance coverage. They need help negotiating with their school district. They need help with their insurance plans. Legal assistance can be enormously helpful. Parent support groups can be also extremely helpful. 501c3. Why would we need a 501c3? This was a hospital-based program. Why would we need this? Well, because the program hires a lot of individuals who are non-revenue producers. Our family resource coordinator, for example, or our social worker, our clinical coordinator is not a financial viable person. We're not getting paid by the insurance company to support those people, and yet they are extremely important components of this whole program. So what we did was we developed a program for parents that included parents and professionals, which at the time was called Friends of Ladders. And we developed it as a tax-exempt organization with the goal of raising extra money in order to pay off the debt that we were raising. We were running a deficit in this clinic, despite everything we were doing, of somewhere between $300,000 and $500,000 a year. And we needed to be able to close that financial gap somehow. And so there was the job of these individuals to help us raise the money through various fundraising events, or however, grants, however they helped us. And it was a fairly successful arrangement to be able to do it as kind of an ancillary piece to this project. So how did the Ladders approach operate? If someone was calling in for an appointment, usually this person was referred right to the social worker who did the, why are you coming for the visit? How can we help you? What do you think the problem is with your child, adolescent, and adult? And then would send out an intake packet that would ask for further information, any documents of previous evaluations done elsewhere, an educational plan, so forth, whatever information that we could get that was already existing, so that A, we weren't replicating something that had already been done, but B, would give us the back-end information we needed. The social worker would then make arrangements for an appointment, usually with one of the physicians, and oftentimes that person would be the social worker knew who was in the clinic and would try to match with the patient with the appropriate person. So if this was a 25-year-old person, it would go to the internist, for example. The doctor visit would then happen. The diagnosis would be confirmed, or whatever the problem was would be discussed. Depending upon what the problems were, appropriate referrals were made either within the clinic program or within our network of people that we've already described. The referrals, the evaluations would be conducted, and then once they were conducted and we had the results, the doctor or one of the other individuals who would be sort of that person's coordinator, some person would end up being the coordinator for this family, would go over the data, say, okay, now that we know what the story is here, let's discuss next steps. What do we need to do, either educationally, vocationally, health-wise, what have you, and let's follow along and see how that works out. So anyway, the point was to get a review of all the findings and recommendations, and then to plan out a follow-up so that we could be sure that whatever plan we were coming up with would continue to provide progress. If it wasn't, then we needed to change the plan. But the ongoing follow-up was part of the story. So what is the advantage of having all these people sitting around in the same office? Well, first of all, I think I've already talked about the fact that we learn from each other. I was not trained to know anything about gastroenterology, and I was not trained to know anything about speech and language and OT and PT and frankly even neuropsychology. So I had to learn what these people did, what they could contribute to this story. They were very helpful in providing their own observations that I could learn from. And we now have a number of people who are seeing the same patient, but from different perspectives. And that is an extremely helpful and critical piece of this story. It also is much more efficient in terms of consultation with these disciplines. So, for example, if I thought a child had a motor problem of some kind, I could run down the hallway and I could grab one of the physical therapists and say, could you just quickly take a look at this, or can I tell you my story, and what do you think we ought to be able to do? And I didn't have to make a phone call and wait 3 days for somebody to call me back. And then by that time, I'd forgotten what the patient was and what the problem was I was asking about. So it's a much more efficient way to sort of communicate with people on the spot, because they're sitting there in your own environment and can help you more expediently to come up with a plan. It's also a one-stop shop as well for patients and parents. Services can become very fragmented, and I think there's a huge benefit from having a therapist and physicians and anybody working with these families to be in a position where they can all talk to each other and share information. So you don't have a speech pathologist over in X place, and you have an OT in a Y place, and they don't talk to each other. I think there's a lot of benefit to being able to share this information, so any of these therapists or interventionists can carry over the strategies that are being raised by other people. So it broadens the opportunity to carry over not only evaluations but treatment plans. And so it also, by the way, provides us huge opportunities for interdisciplinary clinical research, and we were able to do a number of projects using multiple disciplines, which was enormously helpful. So as Denise had mentioned, we were really the start of what became what's called the Autism Treatment Network, which still exists and which is now part of Autism Speaks. And in the fall of 2003, I was asked to give a talk in Seattle. Actually, I invited myself to this meeting in Seattle that was totally something else. And somebody said, well, if you're going to go to the meeting, why don't you just talk about ladders, which I did. And I think I, at the time, sort of assumed that everybody was doing an interdisciplinary kind of program, but apparently that was not the case. And they were very interested in it, and so it became an entity known as Autism Treatment Network that was funded at that time by a local group out of Oregon. In any case, there were 5 academic sites that were the original groundbreaking group. That you can see here: University of Washington, Baylor, Columbia, Oregon Health Science Center, and MDH, Mass General Hospital. And then again, it involved a multidisciplinary approach of these medical teams. It involved the use of common protocols and a commitment to data sharing across these sites. So the idea was that we really wanted to get some broader band information and come up with some combined programs here to evaluate and treat individuals on the spectrum. So what was the value of a consortium? I already started to talk about that, but how do you identify the red flags that would make us want to do a more detailed assessment? And are these red flags, frankly, valid? Okay, I talked a little bit about red flags when I was talking about the mitochondrial disorders, but are those valid? Well, we thought they were, but maybe other people need to check it out, or maybe there are other quote red flags that we need to identify that we haven't even thought about yet. Maybe people are seeing this differently, and so we need to again learn from other people. What proportion of the autism population is affected by some of the symptoms that we're talking about? What percent of them have gastroesophageal reflux disease? Just because we see a lot of it, does that mean everybody else is seeing a lot of it? How is it presenting? We need to have that information. Accurate identification of medical disorders. We've talked about the fact that a lot of these children don't present with the typical symptoms that are easily recognized by many primary care physicians and even specialists. So how can we help people identify what they are? What interventions are the most effective? And we've talked about what works for person A may not work for person B. Can we establish scientifically sound and meaningful standards of care? I hope we can or could, and that was one of the goals. So, any case, the ATN became part of Autism Speaks ultimately, and in January 2007 and again in 2013, they put out a request for proposals in order to extend the number of sites that were going to be included within this program, with the idea of establishing a number of these multidisciplinary sites throughout the country. And currently, there are now 14 sites, and there are 2 in Canada, and the rest are throughout the United States, and are all part of this ongoing consortium. The goal of the ATN is to establish evidence-based data we've talked about with regard to medically related conditions, and to establish standards of health care for children, adolescents, adults on the spectrum. How are we going to manage these children so that they have the best potential outcomes and good health? So in summary, medical comorbidities are important. They're important for the quality of life. We know that better health leads to better outcomes. If you don't feel well, you're not going to do well. There are subsets of autistic persons that potentially we could be identifying genetically and metabolically. This is not, I've said this 3 or 4 times already, this is not a one-size-fits-all. So are there subgroups that potentially we could help? If you were in the subgroup, would this help us identify you better? Would it help us give you more specific treatments and interventions? I don't know, but I think this is one of the questions that could come out of a model like this. Understanding the associated medical conditions could help us understand the neurobiology of the disorder. There is a growing interest now in the gut-brain connection. I think that there may be connections with other organ systems too that help us about understanding the neurology of this disorder. And it's not simply just a neurologic problem by itself. There are other organ systems that are playing a role here, and we need to understand how these multiple systems work together in one form or another. It helps us hopefully to help us to identify diagnostic biomarkers. This is a huge area that people are looking at right now. We still need some kind of help to, when this baby is born and we think this is at risk, is there some kind of blood test, X-ray, I don't know, skin and metabolic test that we could do that would potentially identify this child right from the start, which would then help us to perhaps get a leg up and start working with this individual very early on. Identify the subgroups, which you've already mentioned. The expansion of use of assistive technology, which I think really is an important piece here. There are some very bright children who cannot talk or do not talk officially, who can use these devices probably better than I can, and certainly as you've seen today, I'm not very good at technology. So, and most of them can do far better than I'll ever be able to do. So they're very techy, many of them, and I'd like to see this expanded for their use. I'd like to see better correlation between imaging and postmortem brain samples and clinical phenotypes. So, for example, we can look at brain. Our lab looks at brain tissue under the microscope. One of our problems, however, is that we don't always have good detailed information about what this person looked like during life. How old was he when he started to talk? What kind of behaviors did he have when he was 5? What kind of programs did he have when he was 7? Et cetera, et cetera, et cetera. We usually get something that says he or she meets criteria for autism based on the ADOS or the ADIR. Okay, that's interesting, but that doesn't really help us. And I think there's so much variability here that when people are doing these various studies, including imaging studies, have the same problem. that sometimes one lab will present findings that are not seen in another lab. Does that mean one is wrong and the other is right? Probably not. It means you're probably having different subgroups or different populations that are being examined. And until we get to a point where we can have better clinical phenotypes here, I think we're going to still sort of be running around trying to figure out a lot of what's going on here. So I would really like to see some mechanism by which we can get families. I had this idea that maybe we could ask families of children on the autism spectrum to keep a running guide, blog, what have you, on their own home computers about the various tests that their child has had during life in the event that he or she becomes part of the study as they grow up. That way we would have that clinical data way back when and would be in a better position to be able to make these correlates and make them more useful. So one of the other areas I think is of interest is what is the longitudinal story here? What's the natural life history of disorder? I don't think we really know that answer. It's not good enough to just look at a bunch of kids at the age of 3 and another bunch at the age of 10 and another bunch of people in 20s and another bunch when they're 45 and so forth. Those are different groups of people. What needs to be done somehow, I think, is to be able to have studies where you're seeing the same population over time longitudinally. I don't think I know of any organization that's probably going to fund that, although out east there is a program that's called the Framingham Study, which I think was originally designed to follow nurses. But they've been in business for like many years. I don't even know how many years, 40, 50 years, I think, where they've been following the same population of volunteers over a period of time and gotten some very interesting data about hypertension, heart attacks, and so forth and so on. Why couldn't we do something similar like that for the autism population? I think that could be extremely helpful and possibly could give us some clues as to what's going on metabolically as well as developmentally and neurobiologically. Future directions, I'd like to see better correlations between genetic phenotypes and clinical phenotypes, which we just talked about. The differences between males and females has become a hot topic. I think there's a growing sense that a lot of the females have been missed, and there are probably more of them than we appreciated. And I can say from personal experience that I've seen now a growing number of females in their 20s and 30s that are only now just being diagnosed and clearly are on the spectrum, there's just no question, but have been carrying various psychiatric diagnoses, bipolar, anxiety, depression, you name it, been placed on a bazillion different medications in one form or another. I think we just are not, they're presenting differently. They don't always present with the same kinds of repetitive and stereotypic behaviors. There's a theory that they learned how to mask some of their difficulties, particularly social issues. I had one mother come in who's on the spectrum, who has a son that's on the spectrum, as it turns out. And she said that she basically, a very verbal lady who said, you know, when I was a teenager, I watched what other girls did and I followed what they did. And then I imitated what they did. So they, you know, some of these girls have figured out how to pass, if you will, and can fool you when they really are in much more trouble than I think we've come to appreciate. Studies of gastrointestinal disorders in the brain, we've sort of alluded to that connection between the gut and the brain. Meaningful employment for adults, yes, absolutely. I mean, some of these people are extremely talented at what they do. They may have trouble with peer relationships and social interaction, and so we have to help them with that. But these people should not be just wiping tables at McDonald's. They ought to be doing something that's really useful, that they're really good at, and I think we need to get better at looking at that. And then there's the study of aging. Where the heck are the seniors? Where are the autism people in their 70s and 80s? And if we found them, what could they tell us? I've had very real interesting questions about that. There's one paper out there from North Carolina that some of you may have seen that talks about a subset of individuals who had Parkinson's disease. But personally, I've not ever seen anybody with multiple sclerosis. Maybe have 2 patients with cancer, but that's, I think, probably low. Maybe it's my population. But I don't see a lot of adult disorders in my adults. And I don't know why, but I think it's an interesting area that we really need to look at. So in the upshot here, I think if we do our job right, we can make a big difference here. I think we know that early diagnosis and intervention makes a big difference in outcomes. When I was a resident, the kinds of kids that were labeled as autistic were kids that sort of sat back and forth, no eye contact, slapped, and had no language. I can't remember seeing a child that looked quite that dramatic in the last 4, 5, 6 years, or maybe even longer than that. So we're doing something different here that we're not seeing these really dramatic, really what I would consider severely impaired individuals that I saw when I was a resident. There is data from the group out of UConn from Dr. Deborah Fine, FEIN, that looked at children in terms of whether they lost their diagnosis. And there are a subset of children who are given services by the time they're 6 or 7 no longer meet criteria for autism spectrum disorder. Why those kids and why not everybody else? What's different about them? Are they, genetically different? Are they, who knows? But I think that's an important question that perhaps we need to look at a little bit more. Treating medical disorders will result in better outcomes. And as I said earlier in this talk, if you feel better, you're going to do better. Nobody does very well if they don't feel well. We need to look at identification of autism subgroups because this may help us not only in terms of diagnosis or treatment plans. I think that we can do better in terms of the availability of services. I think in some areas we are. And then I think some symptoms do improve with age. So frankly, a lot of the adults that I see don't have the stereotypic behaviors that they had when they were younger. They do seem to have better eye contact. They do seem to be look a little bit more socially related than they did when they were younger. So what's that telling us about the ongoing story here, which gets back to looking at longitudinal history here? What can that tell us about the underlying neurobiology of this disorder? I think it's a fascinating disorder. I don't think anybody studying this group of individuals will ever be bored, and it's an ongoing challenge. So with that, I'm happy to take any questions.
We have quite a few questions, so I'm going to jump right in with those.
Okay.
The first one's about Asperger's. So they were asking, why was it removed as an official diagnosis? What was the rationale?
I wish I knew. I was not on the committee. My guess is that because it's, I don't know. I think it's the way that the definition of autism spectrum disorder has now been broadened, and that they were seeing this as the upper end of the autism spectrum. I don't really like to use the term high functioning, low functioning. I don't think that helps me, but I think that was probably what it was. But I wasn't on the committee, and I honestly do not know why it was taken out. My guess is though that there's the idea when the DSM-4 came out. There wasn't the appreciation that there was a quote spectrum. You had these autism and PDD-NOS, where Rett syndrome and so forth, childhood disintegrative disorder, or whatever it was at the time, were all sort of seen as separate entities. And I think what happened was that they really began to appreciate that there was a broader range of symptoms, signs and symptoms, all of which could be captured under this term quote spectrum. So I'm guessing that that's what happened. But I think honestly, the Asperger's people and the adults I know with Asperger's, first of all, most of the time they're pretty ticked off about the fact that they got eliminated. And you go to a meeting and somebody will stand up and say, you've done away with my identity. They're really ticked off about it. Because I think that's given them an identity, and they're frankly happy to have that identity, and it gets them what they need, and they have friends and their colleagues who share the same diagnosis. So my sense is it's going to be there whether it's an official diagnosis or not. And that's a term, frankly, I still use.
All right. The next question is about catatonia. Just a little more information about patients you've had experiences with catatonia, or how you see that relating to as a comorbidity to autism.
How you guys are asking me the tough questions. Okay. Again, catatonia is a very interesting topic about, frankly, we need a heck of a lot more information. I've personally seen it usually in teenagers and kids in their early 20s. I think everybody probably knows how it presents, but it's almost like they're frozen or they get stuck. It's not quite like Parkinson's disease where there's sort of this difficulty initiating motor movement, but that's that component, but they don't have other sort of Parkinsonian-like symptoms. I don't know that we really understand the underlying neurobiology of it. There are a number of medications that have been used. I have a young lady now in California that we've been using Ativan with, who frankly has made some really good progress with that. There's also electroshock therapy that has been used that in some cases been found to be effective in managing it. But I think this is a huge area for research. So the person asking the question wants to take this on, this would be a very valuable area for further research. I wish I knew more about it, but it's a tough problem to solve, quite honestly. The Ativan can be helpful, but and frankly, I'm really not wild about the concept of electroshock therapy, but I know that there are studies that have shown that it's been helpful. So if it works, it works.
All right, the next question's about PANS. This person's asking about, have you noticed any difference between patients who are on the autism spectrum and have PANS symptoms and patients who are not on the autism spectrum but are diagnosed with it?
Quite honestly, that's me personally. I don't see a lot of patients just who are neurotypical. So I'm not sure I'm the right person to ask that question of. Most of the people that I'm seeing are, because of my practice, are on the autism spectrum. So I'm not sure that I can really answer that question very effectively. I don't know.
Okay. As a neurologist, this is, I think, a well-suited question for you. Is it possible to have a seizure and be aware while it's occurring? So this parent's asking, can my child on the spectrum, do they know they're having a seizure when it's occurring?
I don't know that they know that they're having a seizure. Some people know that something happened, but I don't know that they, at least the ones that I've seen, even people who are neurotypical, don't typically tell you, I remember shaking, I remember whatever. They may say I was distracted, or I sort of remember tuning out or something like that, possibly. But in somebody who's having a major motor seizure, I don't remember anybody ever reporting, that they knew what was really happening to them. They know that they sort of missed something or something happened, but I don't think they're really in any position to describe it.
Okay. So your sense of this, I mean, you've been around our community for many years. So what is your sense of how aware parents and families are of the likelihood of medical comorbidities with autism?
Actually, not as aware as I would hope, frankly. I don't think it's been well publicized. I think it's better in some cases, but not. And I don't think that's something that families will come in and say, I think my child's got some kind of, gastrointestinal problem or something. They'll come in and say, it's difficulty with sleep. Sometimes they don't always present that with that either. Sometimes you only find out because you've asked the question. It's not necessarily something they come up with. The typical thing that we get involved in is some kind of behavioral issue, or school isn't going well, or the very young kids who aren't speaking. But I mean, the fact that somebody would come in and ask about medical concerns, almost, I wouldn't say it never happens, but it's really pretty rare. It does happen periodically, but not very much. And I think we really have not brought that to the forefront as well as we should.
Okay. So with our loved ones on the spectrum, it can be difficult to get an EEG just because of challenges that we can experience. But if an EEG is successfully implemented, are all seizures caught on an EEG, or are there some that they're not?
No, they're not. And that's probably why I really like the videos, if somebody can capture the videos. No, because what you're doing is most people probably in this call already know that, when you're doing EEG, you're putting electrodes on the surface of the scalp. So if the abnormal electrical activity is fairly surface placed in the brain, yes, you'll probably pick it up. But if you have a seizure focus that's down deep in the brain, you may not pick it up because it's maybe too far away from the electrodes to be picked up. There are places where they would put electrodes, and nobody's going to do this to an awake person, I don't think, where they would feed something back into your nasal cavity or into the back of your throat to try to, put it closer to the deeper part of the brain, so forth. But I think most people these days will say, okay, well, we didn't pick it up, but I know that he or she is having these events and it looks like she or me, and therefore I'm going to go ahead and treat the patient. Story. I don't think that anybody that I know from a clinical perspective, unless they're doing a research project, is going to do some of these rather more invasive approaches. But it is certainly possible to have clinical seizures and have a perfectly normal EEG. It's also possible, by the way, to have a funny-looking EEG and not have seizures. So EEGs can be helpful, but I think you still need to be able to correlate with what the patient's actually doing. So that's kind of why I like to have the 24 or 48-hour ones if I can get them, because it gives us a broader band, a broader opportunity. But honestly, having somebody take a quick thing on their, everybody's got a cell phone, and everybody knows how to take pictures on a cell phone or a video, and that is so incredibly helpful that it's probably one of my favorite things to do.
Okay. If somebody is anesthetized during an EEG, does that affect the outcome? So if they're knocked out?
Yes, I think we try very hard not to anesthetize them because that can depress any kind of electrical activity that you might have on the EEG. So yeah, we try very hard not to do that. In fact, that's somewhat that if you want to try to suppress somebody's EEGs somebody's seizures who's having some seizures, one of the ways to do it is to use anesthesia. So it's probably not a good idea to do that.
Okay, so PANS and earlier PANDAS they're pretty new diagnosis, and they're fairly new in the medical community. So do you have any perspectives to share just about assessing patients and considering that diagnosis, or what the steps are, or things that parents can do if they need to reach out to a specialist about suspecting that their child may be experiencing that after a incident with strep or another?
Yeah, okay. Well, I think, if there's some unusual behaviors that are exhibited, and there has been some history of strep infection, it probably needs to be looked at. There are some lab tests that you can do to try to screen for it. It should be noted, however, that there are some academic hospitals, practices that don't believe in PANS or PANDAS, so they don't necessarily look at it. There are also people who specialize in it. I think that Sue Sweeto and that the NIH has done an extremely good job of bringing this to the forefront. I think she's a very good investigator and clinician, and I don't think this is a crazy idea at all. I think it's real. I think it's also something that can and should be treated if it's identified. But I think somebody has to think about it and do the lab test or whatever we can do to try to identify it, or at least raise the question that it might be there. And oftentimes, if I think that it may be a possibility and I've seen something that looks like that, I usually will refer to one of the specialists who are now in the Boston area or something. There are a number of people throughout the area that specialize in the treatment of PANDAS or PANS. And I would generally send these kids, children, adolescents, adults, patients to those individuals, because they know far more about it than I do, and are in a better position to treat them. And a lot of the kids, in fact, most of them do very well and improve, although there are some kids who seem to have a more chronic course over a period of time and end up having IVIG, intravenous work. I have to go on these interventions because it hasn't gotten better with the usual antibiotics that are given. So it can be tricky to treat, but I think it's also a treatable disorder if it's handled well.
So if parents are hoping to take their child to a multidisciplinary clinic, using the ladders model, how would they find a resource in their area?
Well, I think that probably at least the first place to do would be to go online at the Autism Speaks group and see if there's somebody that's been identified in my group that's near them, that's part of that consortium. That would be the first thing to do. I think most of these are probably located in or around various medical centers where they have options for these multidisciplinary clinics. Some of them are not well known, I grant you, but parents also connect with other parents, and being part of a parent support group is enormously helpful. Some of the local autism society groups, you can say, where do if I have this problem, I really want to go to a clinic that's going to involve a number of disciplines. Who do you know anybody around that does that kind of thing? And I think just connecting with other people in the community can be very helpful. But usually whatever is around can be found in some kind of medical community.
Right. And yes, another person on the chat has shared a link. So if you're looking for a location, that link is in the chat right now. Okay. So you've done many EEGs on individuals with autism. So I know you have really talented nurses you've worked with. Do you have any tips, just tips that people have used that help the experience be palatable or at least bearable for individuals on the spectrum?
In terms of getting an EEG?
Yeah.
Is that what you're saying? Yeah.
Yeah, having the sensors and sensory experience.
I guess, I think it's really going to be challenging. Probably one of the things that I usually do is suggest doing an overnight EEG, which goes against, my idea of doing a 24-hour EEG. And, it's really going to be bad. I really say, okay, well, let's have, Jimmy come into the hospital and we'll get him to settle down and we'll get him to go to sleep at the hospital, and then we'll try to put the electrodes on, while he's sleeping. And we'll just run it overnight and see if we can pick something up that way. I mean, I don't think it's ideal, but I think it's better than nothing. I think, I think sometimes the sensory issues are really challenging, and these kids, as you know better than I do, don't like things on their head. So sometimes we will try to get their behavioral therapists to get them to at least wear a hat, or, practice things in advance to see if we can get something a little bit easier so it's not quite so threatening for them. But I think trying the overnight EEG sometimes is a little bit easier because you can do it when they're asleep.